All right, so this is the fourth and last video of the COPD. This one's covering education, rehabilitation, and self-management by me, Nick Riesenberg. So education's key components are to give them education about their disease process. They need to know what's going on in their body and what effects that has. The medication effects, properly demonstrate how to administer their medication, how to properly control their symptoms, oxygen therapy, ventilatory support, pulmonary rehabilitation, and some surgical interventions if it comes to that. So it's an important aspect of COPD maintenance and really any other disease process maintenance. It's important that they know about the disease process, how to avoid certain triggers and what habits can benefit them and what habits can cause further deterioration. And, to avoid any of those risk factors, being educated on the effects of their medication, how to properly use them is also a major contributor to managing their disease, because if they don't know how to properly take it, as we've already talked about, it's not going to do any good. It is our job as providers to offer that education to the patient and give them guidance on how to properly use their medication. We should inform them not only on when to take it, but how to take it and demonstrate it. And that way they know that they're doing right by themselves and that we've done our job as a provider to give them that information. So symptom control, symptoms that COPD patients should monitor include their breathlessness, like, how out of breath are you today compared to yesterday or compared to this morning? How much sputum have you been coughing up? Has it been more? Has it been less? Has it had a different color, smell? Their coughing, fatigue, sleeping disturbances, if they have insomnia, wheezing and chest tightness. Avoid any environmental triggers as well with that, but like just monitoring if they're progressing into maybe an exacerbation or feeling better from the medication use. So treating the exacerbations is the first step. It would be to do your best to avoid one. Try to stay away from those risk factors and smoking, and then that's the first step of avoiding an exacerbation or treating one is not having one at all. And then other methods that have been proven to minimize the risk: smoking cessation, rehabilitation, pulmonary rehabilitation, exercise, lung volume reduction, making sure you're getting adequate vitamin D, and then shielding measures when you're out in public or with people, wearing a mask, minimizing your social contact, frequent hand wash, especially during the seasons that respiratory infections are more relevant. So other options for the treatment of COPD exacerbation was systemic steroids, antibiotics. They're indicated if they have at least two of the three cardinal symptoms: increased sputum purulence, volume, and dyspnea. SABAs are indicated in acute exacerbation to help relieve the feeling of breathlessness, which we've talked about extensively. So pulmonary rehabilitation, defined as a comprehensive intervention based on thorough patient assessment followed by patient-tolerated therapies that include exercise training, education, self-management, intervention aiming at behavior change, designed to improve the physical and physiology, that word, condition of people with chronic respiratory disease, and to promote long-term adherence to health advancing behavior. So not only do we want them to be physically better, but also mentally better, because it has that depression and that feeling of less a capability in themselves. So it's going to start with initial assessment. This is to make a tailor-made rehabilitation plan catered to the individual to address their specific needs and the abilities to achieve a greater outcome for the individual. That assessment could consist of a detailed history and physical examination, measurement of the post-bronchodilator spirometry, assessment of exercise capability or capacity, measurement of health status and impact on breathlessness, assessment of inspiratory and expiratory muscle strength and lower limb strength in patients who suffer from muscle wasting, because a lot of these people are sediment. They don't feel like doing anything. They don't feel capable of. They're out of breath and everything, so their muscles are deteriorating because they're not being physically active. Discussion about individual patient goals and expectations, like what do you expect from this pulmonary rehabilitation, and what are your goals of it? And I've found in my rotation that a lot of people go in not expecting very much. I had a lady who had a complete lung reduction on one side. The right lower lobe actually was completely removed, and she was amazed by how much she had progressed in I think it was almost 2 months. She was very surprised. She did not expect it at all. So, and after that initial assessment, an exercise regimen is made for them, and they're going to be supervised at least twice a weekly is recommended for the pulmonary rehabilitation. So they're going to have endurance training, interval training, resistance/strength training, walking exercises, flexibility training, and inspiratory muscle training. Optimal benefits are achieved from the program lasting 6 to 8 weeks. So we want them to come at least twice a week and go for at least 6 to 8 weeks so we can really get them to where they need to be. So the goals are to increase their exercise capacity, education of their disease process, improve physical and psychological condition, that's the word, of people with chronic respiratory disease, reduce the symptoms of their anxiety or depression, make them feel better about themselves so that they can go and do more than they think they can if they just work at it. And also them being in a facility with people that have like-minded symptoms or diseases and feel the same way, that they all progress together. It's a good community that helps with that anxiety and depression aspect, and improves the patient's ability to complete daily activities and enhance their overall quality of life, because that's what it's for. You know, you're living with this disease process, but maybe we can help you live with it a lot more effectively and make you happier in the long run, hopefully give you longevity of your life as well. So another thing is oxygen therapy. Long-term administration of oxygen increases survival of patients with severe chronic resting arterial hypoxemia. Big words. If they have low oxygen capacity, a long-term administration will help them. It's indicated for stable patients who have a PaO2 of below 55 or SaO2 below 80%, with or without hypercapnia, which is a high amount of CO2, confirmed twice over a 3-week period. And then another indication is a PaO2 between 55 and 60, or SaO2 of 88%. There's evidence that pulmonary hypertension, peripheral edema, suggesting heart failure, or polycythemia. So if they have any of those things, we want to consider giving them oxygen therapy. Patients with stable COPD and moderate resting or exercise-induced arterial desaturation, prescription of long-term oxygen does not really lengthen their time to death or first hospitalization, or provide sustained benefit in the health status, lung function, and the 6-minute walk distance. So this is for people that's having more issues than the most. They don't really need the long-term if they're not having all those problems. After being placed on long-term therapy, patients should be reevaluated after 60 or to 90 days with a repeat arterial blood gas or oxygen saturation measurements while breathing room air, because we want to see what they're on their normal without us giving them supplemental oxygen. And we want to prescribe them their oxygen, determine on how they're doing in their own status, so that it benefits them most, because you don't want to over-oxygenate somebody that's on COPD. We all know the effects of that. So this is just a little diagram that's showing that that kind of breakdown. What we already talked about, that first level, and then you prescribe it and you try to titrate that SaO2 to 90% above or equal to, really between that and like 92 for COPD. We don't want to over-oxygenate them, and you want to reassess after between 60 and 90 days. So ventilatory support, not oxygen, but just ventilatory. They need help with their ventilatory efforts. You can give them a non-invasive, which is NIV ventilation, is occasionally used in patients with stable, very severe COPD. So this is for people having more problems than most. It's considered with patients that have pronounced daytime hypercapnia and recent hospitalizations. COPD and obstructive sleep apnea are clear indications for CPAP, continuous positive airway pressure. So if they have both those together, we definitely want to prescribe them a CPAP and show them how to use that. Non-invasive positive pressure ventilation, so MPPV, not to be confused with NIV, is standard care for decreasing morbidity and mortality in patients hospitalized with an exacerbation of COPD and respiratory care. So if they're in those kind of lower end stages, we want to give that to them, to give them as much comfort and help them as much as we can. So that leads us to surgical interventions. You can have a lung transplantation, lung volume reduction surgery, LVRS. That's what I was a little bit talking about with that lady that I was talking about, and then a bolectomy. And we're going to talk about those individually here. So a lung transplantation should be considered when they have a progressive disease despite maximal medical treatment and are not candidates for a lung volume reduction surgery. So if it just keeps progressing, and no matter what we do medically, and they're not a candidate for the lung volume reduction, so that would be the prior step if you can, then we want to consider them for a complete lung transplantation. It has been shown to give a survival benefit of a 2-year benefit in 2 out of 5 transplanted COPD patients. So almost 50%. I mean, it's really not the fantastic option, but when you run out of options, you got to choose something. Something hopefully will help, and this is kind of that last-ditch effort for them. Lung volume reduction surgery. It's to reduce the lung hyperinflation, which is a major contributor to impaired respiratory function and is associated with increased hospitalization and mortality in COPD patients. In the surgery, the most emphysematic portions of the lungs are resected to reduce hyperinflation and increase elastic recoil and density. These structural changes can significantly improve expiratory flow and the chest wall, respiratory muscle, and cardiac mechanics. So it's also been shown to prolong survival compared to medical therapy in a very select group of patients with severe COPD, predominantly upper lobe emphysema and low exercise capacity. Although in patients with non-upper lobe emphysema and a high exercise capacity, mortality was higher in that surgical group than in the medical group. So you're not always going to be in need of this surgery. It's more of if you have that severe COPD and a predominantly upper lobe emphysema and a low exercise capacity. So bulectomy, it's rare. It's an effective procedure for surgical resection of the bulla that occupies over 1/3 of a hemothorax and compresses adjacent viable lung tissue. It can reduce dyspnea, improve lung and respiratory muscle, cardiac performance, and exercise tolerance. So all of these are the final kind of steps, if we can get to with a patient, because you don't want to do a lung transplantation. The reduction surgery is only for a specific group, and a bulectomy. All these are invasive, very invasive surgeries. So you want to avoid that if you can. But if it gets to that point, you got to help if you can, and it gets to a point where it's either this disease is processed to the point of death is occurring, shorter than quicker rather than later, then you want to think about these different surgeries. And that concludes the COPD presentation. I hope you enjoyed it. I definitely learned a lot more of what I thought I knew going into it and the more stair-step process of things. But I hope you enjoyed it. And this has been Nicholas Riesenberg for the third video. And thank you very much.